Okay. Good evening, everyone. We are honored to stand in front of you to share with you the pelvic floor architecture mapping using the diffusion tensor imaging on behalf of pelvic floor imaging unit and research lab. It's me, Shrouk Ali, radiology resident at القصر العيني.
Good evening, everyone. My name is Marsail Naguib, radiology resident at Qasr Al-Aini. And today we have two cases. My first case is a 50-year-old male patient presented with straining during defecation with sense of incomplete evacuation for 5 years. We recommended MR defecography because the evacuation phase gives us a crucial insight into the underlying mechanism of each patient's symptoms. The MR defecography revealed dysynergic defecation, which is evident here by puborectalis dyskinesia. It's seen second, without opening of the anal canal, the anorectal angle becomes more acute instead of being more obtuse, with evidence of anterior abdominal muscle contraction. The management plan for my case was conservative by botulinum toxin injection, physiotherapy, and biofeedback.
The second case, 37-year-old lady presented with symptoms suggestive of obstructed defecation syndrome. MRI defecography was recommended and done. It revealed pelvic floor weakness with rectocele, which is bulge in the anterior rectal wall, cystocele, and uterine descent. The management plan for my case was conservative by physiotherapy and biofeedback.
We did follow up after 6 months. The first case diagnosed with dysynergia has improved, but the second case diagnosed with pelvic floor weakness got worsened.
So MRI defecography for follow-up and comparison was done. Surprisingly, it revealed almost the same dynamic finding as before the treatment, regardless of the symptoms, either improved or worsened.
So now we have a clinical question: how to justify the change in symptoms with no appreciable changes in the MR defecography? Going back to literature to search about an MRI sequence that can answer this, that can help to justify. We found the diffusion tensor imaging is an ambitious technique to assess the microstructure of well-organized tissues like muscles and nerves. It has been first created and used in the mapping and delineation of white matter tracts in the brain.
Mapping and delineation, this is typically what we need.
Yes, Shrouk. And recently, the use of DTI in the assessment of different muscle groups, and it has been found very valuable in different traumatic and non-traumatic conditions. So now we have a question and a tool, which is DTI.
So we couldn't have missed the chance and the opportunity for research. We have a study conducted in pelvic floor unit and research lab, Qasr Al-Aini, Cairo University, conducted and published in 2021, based on our deep belief that the integration of diffusion techniques in the pelvic floor imaging can provide for us valuable insight into the deep structure of the muscles, which can help us solve the discrepancy between the clinical symptoms and radiological finding. But hold on, to fully understand the idea of the study, we have to first understand the concept of diffusion. And by diffusion, I mean the diffusion of water molecules in our body. The water molecules diffuse randomly via Brownian motion. According to the type of the tissue, we have two types of diffusion. The first type is isotropic diffusion, in which the water molecules can diffuse equally in all directions with no boundaries, like in figure 1, in pure water and gel. And the second type is anisotropic, that occurs in soft tissue in which the diffusion of water molecules is embedded by cell membranes and intracellular organelles. It can be medium diffusion like in the normal parenchyma. It can be restricted due to either many cells like in tumors and abscess, or restricted due to the swelling of the cells like in infarction. An important term is the ADC, the apparent diffusion coefficient, which reflects how freely the water can diffuse. The higher ADC, the more the free diffusion is, the less obstacles or barriers the water faces.
So after talking about the diffusion, let's talk about diffusion tensor. So simply talking, the diffusion tensor is the combination between diffusion and direction. As Shrouk said, the water molecules move freely like in gel. What happens if we take these water molecules and put them on well-organized fibers like the striated muscles? What happens? The water molecules move freely, but along the organized muscle fibers of the striated muscles. And the quantification of this is called fractional anisotropy. And we will give them numbers. If the direction, only one direction, it takes number 1. What happens if the organization of these fibers got disrupted? Like in any pathological disease, the fibers got disrupted and the water molecules start to move in different directions. And the number start to decrease towards 0. يبقى 0 معناه perfect isotropy. But 1 means perfect anisotropy. Perfect isotropy, which is 0, means equal movement of the water molecules along all directions equally. So my note here, that the striated muscle have high fractional anisotropy, but not equal to 1. It's called moderate fractional anisotropy. Let's apply this to processing of DTI. Image A, 2D of fractional anisotropy map, 2D gray. Okay, B is an axial anatomy T2. C is the color coded of fractional anisotropy. And D is the combined and fused the anatomy with the color coded fractional anisotropy. E is a representation of one of the muscles that we have traced in our study with the Roy applied on the right and left puborectalis slings. Another image from literature, A represent axial T1, B represent axial T2, C represent diffusion, and D represent the color-coded direction of fractional anisotropy. When we apply the whole volume seeding, we have image E, which represent the 3D tractography of complex anatomy of pelvic floor muscles. We have an animation. We have an animation of the 3D tractography of pelvic floor muscle, with each color represent a different direction. Like, for example, the red represent right to left, green anteroposterior, and the blue craniocaudal.
So, going back to our study was conducting with 3 adult patients with different pelvic floor disorders. They have done both static and dynamic MRI, and the control candidates, they have done the static only. Both groups underwent the DTI technique. The result was a big surprise. The fractional anisotropy was found significantly increased, and ADC was lower in the patient group in comparison to the control group. But hold on, we can explain. Going back to basics, the structure of the striated muscle, as the pelvic floor muscles in nature, they are striated muscle in which the muscle fibers is highly organized. It's arranged in a parallel manner. which allows the water molecules to diffuse along, not across the muscle fibers. So what happens if the muscle got injured? Any micro injury, whatever the cause, will lead eventually to collagen deposition. The collagen fibers are more highly organized and with very direction orientation more than the normal muscle fibers. So this means more boundaries to water diffusion, decreasing the ADC. And this restricted diffusion will be more in a specific direction, elevating the fractional anisotropy. So even though the function is worse, diffusion becomes more anisotropic. Regarding the risk factors from the history taken from the patient group, first, pregnancy-induced extracellular matrix changes. The muscles become more stiff to accommodate the progressive increased pelvic pressure. Then childbirth-related muscle injury, especially if it's not visible on the conventional MRI. Extracellular matrix remodeling in stress urinary incontinence and pelvic organ prolapse. This is influenced by hormonal traumatic stress and aging factors.
So, our take-home message today, DTI opens a new horizon in pelvic floor imaging by providing a deeper insight in microstructure of the pelvic floor muscles beyond the routine conventional MRI, bridging the gap between clinical symptoms and radiological findings. So, when you are lost in this era, think of DTI. Thank you.
Thank you so much.